All right, well, thank you everybody for coming to my presentation on sharing clinical records, direct secure messaging, and clinical document exchange. My name is Jen Marsala. I'm a project manager and a business analyst on the clinical data exchange team here at PCC. I've been here 6.5 years. Feels like 2 or 3, but it's been 6.5. I'm excited to be here, and I've got a lot of information to share. I'm going to ask that if questions arise as I'm going through the slides, if you could just jot them down, we'll address them at the end. There should be plenty of time for that, thinking at least 15 minutes or so. So before we get started, by a show of hands, how many practices aren't using either of these solutions? A few. Okay. And then I assume the rest maybe are using one or the other. Okay. All right, so as we get started, let's just go over the learning objectives for the course. I hope that when the session's over, you'll leave here with an understanding of what CCDA documents are and how they support the exchange of clinical data. CCDAs are the cornerstone of exchange, so we're going to spend the first little bit of the presentation focused on those. I also hope that when you leave, you'll be able to explain to a colleague at your practice the basics of how DSM and CDE work, how they can be used to send and receive records, how they're complementary solutions. And finally, I want you to leave knowing how to get your practices set up with DSM and CDE if you're not using them already. All right, first we're going to start out with like a 30,000-foot view. What is interoperability? It's the ability of different computer and software systems to communicate, exchange data, and use the data that has been exchanged. And this is complex in healthcare today because there's so many different entities that need to interact to provide care for a patient. Interoperability is the answer. It's the way to get all of these different entities' systems to work with each other. Some examples of interoperability are sending a prescription electronically from an EHR to a pharmacy. Another example is a medical device, like a monitoring system, collecting data and then transmitting it to an EHR. And then finally, what we'll be focused on today, 2 organizations sending or receiving a clinical document electronically. PCC EHR is interoperable in a lot of ways. One example is PCC ERX. We also receive in the EHR lab results electronically, and we make connections with immunization registries that allow you to submit and in some cases retrieve data. CDE and DSM are just 2 more ways that PCC EHR is interoperable. They're 2 different ways of sending or receiving a clinical document between 2 systems. So as we get started, as I mentioned, we'll focus on CCDA documents first, which are the cornerstone of exchange. These documents, these clinical documents, are most often exchanged in healthcare today. The acronyms can be a little confusing. CDA, or Clinical Document Architecture, is a standard. CCDA, Consolidated Clinical Document Architecture, is an implementation guide that takes the standard and applies it to define a collection of documents. There are 12 types of CCDA documents. The different types serve different purposes. And while what's contained in one might be different than another, they're all kind of made up of the same nuts and bolts, so to speak. PCC EHR generates 1 type of CCDA document, and that's the continuity of care, which we'll talk a little bit more about. So I mentioned that all the types are made out of the same nuts and bolts. They're all made up of sections. They all contain sections which are like building blocks. There's a big pool of 70 sections that make up the different document types. Some examples of sections are medications, encounters, problems, plan of treatment. For every document type, there's some sections that are required and some are optional. For the care plan type of document, there's 2 required sections, goals and health concerns. And then there's some optional sections that are defined for it. Although, if necessary, CCDAs can include sections beyond what has been defined as optional. For the continuity of care type document, remember this is the one that PCC-EHR generates, there's 7 required sections and a bunch of optionals. So in PCC-EHR, if you want to generate a continuity of care document, you'd open up the patient chart, you'd go to the reports menu and select summary of care. So continuity of care, also known as a CCD, is also referred to as a summary of care record in the EHR. All those mean the same thing. If you look at the table of contents, which I've zoomed in on here, the table of contents corresponds to the sections that are included on the CCDA. And when PCC-EHR generates the CCDA, it includes all the required sections so that it meets the standard. In case you're wondering, can I add a section to the CCDA that's not already included? The answer to that question is no. That's something that PCC would have to do, because we'd have to add the section to the template that the EHR generates. But you can configure the summary of care in the EHR so that you're not including information in certain sections. All right, CCDAs combine human-readable text with machine-processable data. And what I mean by that is when you generate the continuity of care in the EHR, it contains words and sentences, you can read it. But behind the scenes, what you don't see, the guts of the document, is actually code. The document is coded to the standard. And it's the standard that makes it possible for the documents to be exchanged across different organizations. Humans think in terms of words, sentences, stories, and computers think in terms of structured and coded data. So I'll just pause here and put in a plug for best practices. The data that you share with third parties is only as good as what you put into the system. So you have to make sure that you enter the data, that it's accurate, and that it's complete. And don't use fields for purposes other than what they're intended, because that could create hiccups for a third party that's trying to process data that you're sharing. For example, if you include notes in a phone number field, that could create hiccups for a third party because they'll run into characters that they're not expecting. So you can kind of think of this first part of the presentation on CCDAs as an appetizer, and now we're going to get into the meat and potatoes. DSM is more like the potatoes, CDE is more like the meat, to be specific. So direct secure messaging is, I'm building this up, but I hope you're not disappointed. It's just really secure email. It's a HIPAA-compliant, encrypted messaging system meant for the exchange of health information over the internet. So how does it work? Direct is a national secure messaging standard, and exchange can't happen unless there's a HISP involved. A HISP is a health information service provider. PCC partners with UpDocs. UpDocs is our HISP. There are a lot of HISPs out there. SureScripts is a HISP, but some of the big EHR vendors out there are their own HISP. For example, I think Athena and Cerner are their own HISP. But we partner with UpDocs. HISPs have a lot of responsibilities. They issue direct addresses, which are different than regular email addresses. They encrypt messages and attachments. They route messages where they need to go. And they also authenticate senders and recipients. When two parties want to exchange direct secure messages and they're using the same HISP, the routing is really simple. The secure messages and files just go through the one HISP to the recipient. But like I mentioned, there are a lot of HISPs out there, so it's very likely that a third party you want to exchange with uses a different HISP. And in that case, the HISPs just have to talk to each other, do some identity validation, and then the messages and files can go on through from one HISP to the other onto the third party. And the flow is the same backwards when the EHR is receiving a direct secure message. So if you decide to go live with direct secure messaging, you'd go through training, the functionality would be enabled, and you'd designate certain users certain staff at your practice to become direct secure messaging users. And out of the gate, those DSM users would have access and could search the UpDocs directory. And the UpDocs directory contains contacts and their direct addresses, which you need to send a direct secure message. You need the address. All the other HISPs also have directories containing their clients' contact information and direct addresses. All the HISPs together, the ones that are accredited anyway, form the Direct Trust network. If one of the DSM users at your practice goes through identity proofing with Direct Trust, all the DSM users at your practice get access and can search and be visible in the Direct Trust directory, which is bigger than just the UpDocs one. That being said, finding direct addresses is challenging and can be an obstacle. And there are a few reasons for that. One is there isn't a standard for a DSM directory, so the HISPs can do it a little bit differently. Two, there isn't a requirement for HISPs to share their directory, so you don't necessarily have access to another HISP's directory. And three, individual users sometimes opt out of having their address be made visible or searchable. But if you can get past that and find the direct address you're looking for, whether it's by searching the directory or just calling up the third party that you want to exchange with and asking for their address, as long as you've got the address, DSM provides a safe and secure and efficient means of exchange. So the next like 7 or so slides, I'm going to show you what DSM looks like in the EHR so that you can get a sense of the solution. Hopefully you can see this. I thought the screen would be bigger. So when you want to initiate a direct secure message in the EHR, you'd go into the patient's chart and you would generate a summary of care. And once you generate that, you would select referral or transition of care. In this example, I'm selecting the dermatology referral. Once that's selected, because I've selected a referral, I have the option to limit the information that I share in the CCDA just to the referral encounter, or I could uncheck that box and I can send the complete CCDA with all the available information for the patient. At that point, just make sure that send via direct secure messaging is selected and you're ready to click send to. And the next step would be to enter the recipient's direct address if you know it. If you don't know it, you can search for it because the to field is also a search field. And again, if you've had someone at your practice go through the ID proofing with Direct Trust, you get to search the larger Direct Trust directory instead of just the UpDocs one. One thing I'll add is that direct addresses, again, are not the same as regular email addresses. In order for a direct secure message to be exchanged, it has to go from a direct address to a direct address. So once you've got the address entered, you can enter subject, message, and you'll notice under the attachments, you're sending the continuity of care document that you generated in the previous step. You also have the option of attaching a file from your workstation or attaching a document from the patient's chart. And then you click send. And that's it. That's it for sending. As far as receiving, it's also pretty straightforward. If a local hospital or a specialist sends you a direct secure message, it would wind up in the messaging queue, which you can use the filters at the bottom to more easily identify what's coming in. From this screen, you can open the Direct Secure Message up. We're going to open up the one for Todd Gack. This is what the message looks like. There are two, in this example, there are two attachments. One is a CCD, and one is a PDF. And you can view either of those using the tabs at the top or the view buttons below. There's also a save button in case you want to save either of those attachments to your workstation. If you look up at the top, and I hope that you can see it, it says patient information from the continuity of care document. Because a CCDA has been attached, the EHR can extract some information from it, the patient's name, date of birth, sex, and then make some helpful suggestions on the right panel about who you might want to attach the message to. There's also basic information displayed about who it's from, what the subject line is, and what the message is. Yesterday, during the Back to the Future course, I mentioned that in 9.7, you'll be able to, well, the EHR will be able to extract CCDAs and PDFs from zipped attachments that come in, which will be handy because we're seeing a lot of that coming from certain third parties. The zip comes in, and you can't do anything with it except just save the whole thing to your workstation and then go through it, try and find a PDF or CCDA that's contained within it. The EHR will do that for you as of 9.7. As I mentioned, on the right-hand panel, you can add the message to the patient's chart, which is what we're going to do in this next step. The message has been added to the chart. You'll notice on the left there's a protocol. You could add components to the protocol. This one has just Direct Secure Message and tasks on it. Since a CCDA has been attached to this message, and now once you've added the message to the patient's chart, you have the option to reconcile the CCDA. If you click Reconcile, it's going to pull up the reconciliation workflow. Currently, you're able to, in the EHR, reconcile three particular sections of the CCDA. Those are problems, medication allergies, and medications. So for those three sections, you can compare what's in the CCDA versus what's in the patient chart, select any items you want to import, and import them. And that is essentially how to receive a Direct Secure Message in the EHR. If you go through the training, I think there will be a little more details and tidbits that you'll pick up, but this hopefully will gives you a sense for what this is and what it looks like and how it works in the EHR. So here's a few statistics, and the ones that are in the first bullet are from just the first quarter of this year alone. Basically, the takeaway is just that DSM is widely used in the industry and trusted. I think it's obvious, but probably worth saying that in order for DSM to be most useful for your practice, your exchange partners, the organizations you exchange with most, have to be using it as well, right? Okay, so takeaways for DSM. It's a means of safely and efficiently sharing information. It's widely used and trusted. It can be used for different purposes. And it can save you time on the phone, time faxing and dealing with paper. All right, so clinical document exchange this is a very official definition, a system of standards for publishing, cataloging, and sharing clinical documents, which makes those documents available for retrieval by authorized parties across the healthcare ecosystem. So that's not a super helpful definition. We're going to break it down a bit. You can think of clinical document exchange as a conversation between two organizations, and there's 3 steps. Well, first I'll say that first there's the organization looking for the documents and the organization that has the documents. And there's 3 steps that you go through. The first is patient discovery, where the organization looking for documents will say, hey, here's some basic information about my patient. Do you know this patient or have this patient in your system? And the other organization will respond, hopefully with a match or multiple matches. In step 2, find documents. The organization looking for documents will confirm the match if the information looks good, and then ask the other system for a list of documents that they might have available. And that other organization will respond with not the documents themselves, but just a list of what they have. In the third step, the organization looking for the documents reviews the list of documents and indicates which ones they want, and then the organization with the documents will send them over. So as I explained that, you probably picked up on the fact that there's 2 different parts of the solution. There's the initiator role, and there's the responding role. PCC has implemented both parts. And if your practice goes live with clinical document exchange, your practice will do both parts. To be clear, on the left-hand side, for the initiator role, your practice is taking an active role, pushing buttons in the EHR, querying other organizations for documents. On the right-hand side, the responder role, that happens without your intervention. Other organizations can retrieve documents from your organization without you doing anything. There isn't anyone, to be clear, sitting at the EHR at your practice responding to queries from other organizations. Okay, so how does this work from a technical perspective? So PCC, we do both parts of the solution. We've built an initiating gateway and a responding gateway. In this example, I'm just showing you the initiator side. You can imagine that you're on the left using the EHR, and PCC's initiating gateway is going to query your local hospital's responding gateway. The conversation that's happening that I mentioned before, it's just the gateways sending messages to each other. And I like to show this slide because there's a couple points I'm going to make that I think the diagram helps make clear. One of those is that the messages that go back and forth and the data, the documents that go across, they go directly from one organization to the other. There isn't an intermediary in between that data is flowing through. Messages are safe and secure. There's encryption involved, certificates, digital signatures that ensure that when you receive a message that it hasn't been tampered with since it left the other gateway. So there's a lot of layers of security involved in this. And then lastly, in case you're concerned about this, no third-party organization has access to your server or your system. Nobody's reaching in and grabbing anything. PCC's gateways, the initiating one and the responding one, they're like the proxies, and everything goes through those gateways. So no one has access to your system. All right, you may have heard of care equality, but maybe you're not sure yet how it fits in with what I'm explaining. So care equality is a collaborative, it's a nonprofit that's been working since 2014 to connect entities in healthcare. And they've defined a framework. Care equality is a framework. They basically come up with the rules of the road for how all these organizations are gonna do clinical document exchange. They have come up with specifications about how to build the gateways that talk to each other. Care equality is not a network. Data doesn't flow through them. It's a framework. PCC is a care equality implementer, and if your practice decides to become decides to participate, you would become a care equality connection. There are a lot of care equality implementers. You'll notice some big names up there. Athena, Epic, Cerner participates, but you don't see their logo because they participate through Commonwealth up on the top row. What was I going to say? There's a point I was going to make. So if one of your local hospitals or exchange partners uses one of these third parties, it's very likely that you would be able to exchange with them. And to be sure of that, I recommend going to careequality.org, active-sites-search, and you can use their search tool. You can search by state, zip, city, and figure out who's a connection in your area. And if you do become a Care Equality connection, your practice would be searchable and you'd pop up in this list for other organizations that are looking for you. Again, just like DSM, with CDE, this solution is most useful if your exchange partners are also participating in this. Okay, so just like we did with DSM, we're going to take a look at what the solution looks like in the EHR so that you can get a sense. So on this screen, this is a practice level configuration that allows you to set default organizations to query. So these defaults will get queried for every patient in your practice when you open up their chart. Any organization that you can find in the search tool on the previous slide would be visible or searchable in this directory in the EHR. As far as where you go to initiate a query, you'd open up a patient's chart, and you'd navigate to history, and then the Find Clinical Documents component. As soon as you click on Find Clinical Documents, once that component opens up, it immediately queries any default organizations that you've set. In this case, I've queried an organization called SCONE. It's an internal server, and a message has come back, patient not found. But you can add organizations on the fly. You might have a patient come in and they're a new patient from across the country, or maybe it's an existing patient but they went on vacation and they went to the ER on vacation. You can pop in, search and pop in any organization that participates, add them either as a default to be always queried when you open this patient's chart, or maybe just one time. In this example, I'm going to add the organization Muffin, which is another internal server. And once I've added that new organization, I'm going to click Find Patient. And after I do that, a result has come back. There's been a match found. And so I'm going to look at that match. I look at the name, date of birth, sex, and address. And if it looks like the same patient, I'm going to confirm the match, and I can click Find Documents to proceed. Now, it's possible that the organization might find multiple matches, in which case you'd have to see what they return back, examine the data. It might be a duplicate that the organization has in their system. And so once you make a determination, you can proceed with finding documents for one or both of the patients. So once you click Find Documents, you're going to get back that list of documents that's available at the other organization. And if you want to retrieve, you would click the Retrieve button. There's just some basic information that comes over in the Find Documents response. The document date, type, status, and last retrieved information. So once you click Retrieve, and the document has arrived in the EHR, you have the option to view or reconcile it. If you click the Reconcile button, this example, by the way, is a CCDA coming in to the EHR. If you click Reconcile, it pulls up that same reconciliation workflow that we looked at in the direct secure messaging. If you click View, it pulls up a document viewer, and you can examine what has come through this way. By default, the document gets saved in Retrieve Documents, but you can change that, and there are a number of other actions that you can take at the bottom of the document viewer. So what kind of documents can you retrieve from Care Equality enabled organizations? So PCCHR supports the retrieval of CCDAs. in the EHR. And that's really the vast majority of what's being exchanged through the framework today. It's possible that other implementers could make other types of documents available, images, but the vast majority, again, of what we see is CCDAs being exchanged, both longitudinal and encounter-based. All right, we're going to flip over now to talking about the responder role. Who can retrieve documents from your practice? So only other care equality implementers and their connections can retrieve from you. When PCC became a care equality implementer, we went through an application process. We were vetted as a legitimate entity in healthcare. All the implementers go through that. When you become a care equality connection, you've got to agree to and sign care equality connection terms. On top of that, PCC only shares documents for the treatment purpose of use. The care equality framework supports different purposes of use. Treatment is one. There are others. I won't name them all, but like payment, coverage, public health activities. PCC is an implementer only for treatment. So that means when an organization makes a query to our gateway, if they're not declaring treatment as the purpose of use, we're not going to respond to it. And that same goes for the initiator role. When your staff are querying and initiating queries for documents, it has to be for treatment purposes, because that's what kind of implementer we are. All right, so what documents can be retrieved from your practice? We make one up-to-date summary of care document available for each patient. And you don't have to worry about stale data going out, because soon after you make changes to a patient's chart, we're updating the CCDA in the background and making an up-to-date copy available. Okay, we're going to talk a little bit about consent. So PCC will only allow a document to be retrieved if the patient consent for that patient is set to yes. If it's set to undetermined or no, we don't share it. In fact, I don't even think if consent is not sent to yes, I don't even think we'll confirm that there's a patient match if an organization's querying about that patient. So it has to be set to yes. Once CDE is enabled on your system, you would find the consent piece of this under communication preferences. That's what it looks like in edit mode on the right side. You've got the three choices: undetermined, yes, and no. So when you go live with CDE, PCC can set the consent status for all your existing patients en masse. That's really easy for us to do. The harder part, and where we find that the part where practices tend to spend the most time deliberating, is about what their practice's consent policy is going to be. We strongly recommend that you obtain legal counsel, talk to your legal team, maybe talk to your malpractice carrier to figure out what your state laws and requirements are. The easiest path forward, if you can do it, is to go opt out, so that from the get-go, all your patients' consent policies or consent status can be sent to yes, and can therefore be ready to be shared. With opt-in, you might have to consider workflows and consent forms, workflows specifically around how and who folks at your practice will be entering consent status into the EHR. I think the biggest takeaway here, if you take away anything from the CDE side of things and you want to onboard with that, is to figure out this consent piece. It's where some practices get stuck. There was one client that went live. They're in an opt-out state, and I kind of assumed that no problem, they'll go with opt-out. but they sought legal counsel, and it turned out that for whatever reason, opt-out didn't apply to clinical document exchange for some reason, and so they had to go with opt-in. So that was surprising and just an example of how complex some of the laws and things can be. Okay, key takeaways. So CDE is like DSM, provides a way to safely and efficiently exchange clinical documents. The neat thing about CDE is that you can provide documents to other organizations without any intervention on your part. And you can create connections between your practice and some of the larger health systems, which I know can relieve pressure in some situations about data sharing. And then finally, just again, like DSM, CDE can save time, resources, paper. Okay, bear with me. My analogy is not perfect, but DSM is kind of like going to a restaurant. It's like a one-on-one interaction. You order your food, you put in the order, you wait for it. While it's prepared, it's delivered to you. Whereas CDE is more like a buffet. You just go up, you see what's available, you take what you want. They're two different dining experiences, but they're both excellent. Okay, how to get started. So the first thing you want to do is identify which of the organizations that you exchange with use these solutions. For DSM, you'll want to reach out and ask, do you use DSM? And also ask them, what's your address? What's your direct address? Just so that you have it while you're talking to them in case you can't find it later in the directory. And then for CDE, you could use the search tool, carequality.org, active site search, to figure out who in your area uses it. And it's not a bad idea to talk to those folks and let them know that you're interested in onboarding so that they know that they can look for you. You want to also contact your client advocate once you've made a decision that you want to go forward, express your interest. And then soon after, you'll be contacted by a member of the clinical data exchange implementation team. You'll go through training and onboarding setup. You can, as always, visit learn.pcc.com for more info about these solutions. And here's the learning objectives again. I hope that you're feeling like you've got a solid understanding of CCDA documents, how these solutions work in general and in the EHR, and that you're feeling good about the steps, how to move forward from here. So at this point, I'm happy to try and field any questions that there might be. Yeah.
So on the clinical document exchange, and going back to your analogy of buffet, you still have just one plate that's your summary of care record, is that right? And then you select what items go into that summary of care, or how does the...
So you're talking about the responder side, where another organization...
If I'm requesting, okay. Do I
Yeah.
request particular fields of data that I want, or do I just request, I just want a summary of care record, and it comes with a lot of information on it?
So when you request, when you do the find documents call after you've confirmed a patient match, the other organization, it's up to them what they make available. So it depends on the organization. It could differ. So it most likely would be a CCDA, but it's up to them, and the number of documents that they provide can vary. But they would send you a list of what they have, and then you can choose, all of them or just a few of them, depending on,
So
the information you have.
Fields from them. I'm selecting documents.
Yes,
okay.
yes, that's right.
So I was just going to try to think of a very tangible real-world example to put it into action. I'm thinking of Epic's Care Everywhere. That's essentially what this is?
Yes.
Okay,
Epic, yeah,
great.
That's what they call it.
Nice. So I send a patient to a cardiologist, a note is written, maybe it's not sent to us automatically, or they're in an emergency room. I get the full note from that encounter, like assessment and plan and everything that the specialist wrote? Or is it more of like the very high level summary document in the CCDA?
It's going to depend on what they provide.
Right.
Yeah.
Okay.
So it's tough to say until you're doing
Different,
it.
yeah,
You're going to
organization by
find out
organization.
as you go what people are supplying you with.
Got it. And just
Yeah.
because I have the mic, sorry, I'm going to pass it to you. But really quickly on DSM, sometimes, so we work with a lot of like nutritionists and other people for disordered eating that aren't part of large organizations and have a very low tech presence. It's not yet possible to just say quickly fire off vital signs for a patient that I saw today to somebody on a regular email address in a secure way through this platform yet.
No, you have
Yeah.
to go through you have to generate
Yeah.
a summary of care to initiate the process.
Right. Generate the summary of
yeah.
care, but then it also has to go to a direct.
Oh, yes, yes,
Yeah.
yes.
Okay, perfect.
Yeah.
Thank you.
So we already use DSM. For the ID proofing, is the ID proofing that we did for EPCS, does that transfer over to DSM, or is that a separate identity proofing that has to be done?
It would be a separate process, and
How do you do that?
I'm going to lean on Betty for a second. The question is how do they initiate the process of going through the ID proofing with Direct Trust? Can they do that themselves, or do we send them a link?
There's a link in PCHR for you to go through the vetting process with the Direct Trust, and it takes you to a web link that UpDocs hosts, and it asks you questions, and then you go through the ID proofing. The only caveat to that is if the person that you set up as your Direct Trust authorized person were to leave the practice and you need to change that person, you just want to call support and let them know that you need to reset that, and we can send you a link to allow you to do that. Did that answer your question?
I don't know whose hand was up first. Got a couple. All right, Mike's coming.
So just for clarification, because I'm not sure I'm understanding this with the clinical document exchange, is this theoretically a way, if an organization or a clinician participates, to get full consultation notes like we expect from a specialist, or are we still limited to CCDAs? So if the organization makes available a full note, is this a way to possibly get it so that a lot of times we don't get consult notes and we have to go hunt them down, and hunting them down involves calling, and then they say, well, you don't have permission, we need the parents to sign a release and whatnot. But it's not clear to me that this is yet a solution for that. And then the second question is, I have friends who work on Epic who talk about how on Epic system they will have every document related to that child from within their health system, 90% of which they never need to see. And it just fills up their inbox, and so they've given up on ever emptying their inbox. Do we have control over what comes in, or I think you kind of showed that, but I'm not sure.
Hi. So the first question was about if you're going to get like a full consultation note, and what we see coming in is the CCDAs. So I don't know that necessarily there would be anything beyond that in there. And the second question is, no, you don't have any control over what comes in. We would return back what the response that we get from the other organization as far as the list of documents that they have available. But we only, depending on what they're making available, we only support viewing CCDAs.
So What your friend is describing is like interoperability with Epic. When a consult note is written, the PMD or the PCP is listed within Epic's system, and so there's an automatic like message that is sent to the provider with a consult note. Different than what this is, which is just like going to query a system and then pulling in notes as you choose to. This isn't like bringing in lots of notes as messages.
This isn't a true HIE. This isn't taking the place of an HIE.
No, right, yeah, exactly. And then I would say that like on average, most organizations through Care Everywhere will include full consult notes through this system. But there are a lot of, like some CCDAs are totally useless. You'll open it up and it's like, cool, there's like a diagnosis and lots of billing information and nothing that I can actually use. But a lot of times I think organizations are including full consult notes now.
I just wanted to, the question was raised about individuals like a nutritionist who may not have this full system and they're not medical specialists, and wanted to point out that in the CHATIS system, there is a referral tracking approach where if there's a screen is positive, there's a refer button that pre-populates a note, and there's an option to say, I attest to verbal consent. It could give an e-fax or an email to a designated social worker, nutritionist, and it also gives a copy of the referral to the patient. And 30 days later, there's an SMS to the patient, and there is feedback. There is a spreadsheet that comes back to the office so you can track your referrals. And this would be like for early intervention for social determinants, and the office indicates their resources. It'll be a social worker who doesn't have any EHR at all. And there's some states that are using that system, and it's available to any CHATIS users in PCC. It doesn't, it's not giving the EHR detailed specialty notes, but it's a message about the screen and any little message that you want to add to it, and the option for them to give messages back. Primary care to mental health is where it's being also used in Florida.
Okay, thank you.
You mentioned that if one person in practice is authorized, then everybody else is also?
For
As far
which,
as-
which solution are
The
you
setup
talking
for
about?
DSM.
For DSM, if,
With
what I had mentioned was if one of the direct secure messaging users at your practice goes through the ID proofing with Direct Trust, then everybody gets
So
access to the.
I'll ask later a
your
separate question
directory.
with BCD with all our different care centers, whether, since I'm signed up, if I can sign anybody else up. I know other people use it besides me, but I'm sure our client advocates set that up because I'm the one who would control their access otherwise, and I know people have it without my doing anything. I have a specific question because although I signed up at the beginning because, I said, this is cool, so let me sign up. Nothing ever happened. I never found anybody that was in the directory or anything like that. I got a message once from somebody who was really cool, and I forget even what I did with that. But recently I've been getting some messages from one of the hospitals by us, not even one we're affiliated with, but they've been coming in a zip format, so
Right.
I just really deleted them, and and if you said now we'll be able to see what they are. But just before I came here, I got a whole bunch of ones. It looks like it's the sender's Optum RX, and they're all to me, and they're about an albuterol recall. So just as a practical example.
Okay.
So I haven't disposed of them. They're in my message queue.
Yeah,
So if I click on it and I look at view, I see there's the message, there's a continuity, and then there's a PDF, which is a copy of a letter, which I think I've actually seen a fax copy of too.
Okay.
So my question is, because I never got anything like this before, if I click on, if I attach, I have to select a patient. If I select a patient and click on save, what's going where? There's a PDF. The wireless connection is here. There's a PDF, looks like a letter. Where's that going to go? To documents or something, or?
it would get attached to the patient, and I don't think it goes to documents. Does it go to documents?
Okay, I'll look at that.
Okay,
And then the other thing
okay.
is there's also there's a message, a continuity of care document and a letter PDF. And the continuity of care document has much the same thing, that blue column with then the stuff on the other side.
Yeah.
Does that populate anything, or is that just informational? You know, I mean, is there putting anything in our system?
If you reconcile it with
Right.
the patient chart, then it would.
Yeah. I'll take a look maybe with you.
Okay. Oh, sorry about that. So the questions were related to direct secure messaging, and one question was when you attach the direct secure message to to a patient, does it wind up in documents? I don't believe it does. And then the other question was, will the CCDA that you're viewing as part of the direct secure message, will that information wind up in the patient chart? And that's only if you reconcile will it do that. Otherwise, it's just something for you to look at.
The direct secure messaging does not end up in documents. It is left in your history field on your.
Visit history.
It's DHR.
And yeah, that was,
Some medical records in that way, and it does not go to a document. We have to, it's in the history.
so we just got confirmation that when you add a DSM to a patient's chart, it doesn't go into documents, but it is accessible. Right, you can get through to visit history. And we'll make a note of that, enhancement request. We'll capture that. Other questions? Yeah?
They're in good shape, you can do it. Maybe there's a question for all the other folks in the room, but whenever I try to call another practice or another place and ask them what their direct secure message email is, I usually get, we don't know what the heck you're talking about. Is there a better way for me to ask that question, or how do you guys actually get those addresses from other places? Because I've almost never been able to get anyone to answer that with, oh yeah, here's our direct secure message. And I don't know if I'm just asking it the wrong way or talking to the wrong people or what, so looking for suggestions.
Yeah, that's a great question. I don't know what else people would be referring to it as. Does anyone?
I think they don't know that terminology.
I think you're asking the wrong people. I think you need to get to the medical record area, the practice manager, because like my front desk don't do direct secure messaging. There's no need for them to do it because they're on phones, they're not doing emails or anything or transferring records.
Records folks usually tell me evacs, and then I want to.
Right. Check with somebody that actually do it. Try the referrals department.
Okay. So, yeah, you know what I should do is I should walk around and we'll have two mics. So, yeah, the comment was that if they don't understand what a direct address is, that maybe it's the wrong person. And you were saying the records folks are probably the best people to reach out to. Other,
What do you also do with, I've struggled with how to manage, we'll get a couple of our local hospitals that send us CCDAs via direct secure messaging for patients that aren't ours. And we then have to, we go through the process of notifying them that they're not in our system and that, you got to send it somewhere else, but there's not, and then we ultimately delete the direct secure message and just don't import it, but it just seems a little not right. There should be a place to park them, I guess, while figuring out what to do with them.
right, they're just sitting in your messaging queue.
Sitting in the messaging queue, piling up, yeah.
Yeah, And what's the response from the organization that you get?
We're sorry.
Yeah.
You know, usually it's patients on Medicaid or some other plans that are incorrectly attributed to us. And we know we have to clean up our attribution list, but we still feel obligated. We don't feel like we can just blow that off. We feel like we're obligated at that point to at least make sure that folks know that we weren't the right person to send it to.
Okay. Well, we can capture that, the need for a kind of, like you said, a place to put them. Looks like one more up here. Oh, I can leave that. Okay.
So just a follow-up to my own question, just because I was nervous to try it before I did, because I didn't know if I wanted it, you know, just going in anywhere. But when I imported that one, you know, I had the whole bunch of them actually, but I just imported one to try, and it does only just go into the history as a direct secure message. So the information there is not going to be particularly useful. There was the document, the PDF, and then there was also the XML document. And neither of them goes anywhere. That you can view them. There's a view button, and there's a save button. But the save button would download them to my server, and not to anywhere in the system. So there's no reconciliation or anything. There's just either look at it or save it to my server at my central office. So I don't know if there's supposed to be anything else, or agreeing that that document might have been more useful if I could put it in some document bucket that I have, as opposed to, now I'll never, I mean, I'll have to remember it's there someday.
Right.
If I ever needed it again, you know.
Okay. We'll capture that. We'll capture that request.
That's okay. Yeah, you can. You can print to the EHR, and then that saves it in the documents folder for you.
Oh, okay. Thanks, Betty. Will's getting a lot of steps today.
I didn't have a question, I just wanted to see him run across the room.
Any other questions?
I was just reflecting on how historically useless CCDAs have been when gotten from other organizations. Is there a way to ensure that the documents that we share out to other organizations are useful, in as much as they include details from notes that other providers would find useful?
Well, you can have a look at the sections that are contained in the CCDs that we generate. Basically, anything in those fields in the EHR gets put into the CCDA, and you can configure which sections will contain.
Oh, so we can configure which sections are included.
Right, of the ones, you can't add any new sections other than what's there, but you
Got
can
it.
go to the summary of care configuration
Got it.
and play with that a little bit.
Do you have a sense that they're clinically useful sections, or which sections they are?
I don't have a sense
Okay.
for that. Here, you can use mine.
I'll be tethered to you. I know that we've had requests to include notes in the CCDAs that we're putting together. So that's a known wish, basically, and something that our team will continue to look at. We definitely have some CCDA improvements kind of in mind that we're trying to sort through and bring to fruition for you. So if you have requests, we'd love for you to stop at the wishing well and just have them write it down, like anything specific that you want to see in the CCDAs that you're producing from the EHR and that you'd like to be able to share.
Thanks, Sarah. That's a great reminder. Other questions? Okay. Well, thank you, everybody.